Hello everyone and welcome to another SDF COVID-19 webinar. Indeed, this is the 16th weekly webinar that we've held. Certainly the 17th of April seems a long time away now. I'm Dave Little, CEO of SDF, and in today's webinar we'll be discussing assertive outreach in Scotland during and after lockdown. This webinar will explore models of assertive outreach being delivered in Scotland, particularly for those experiencing near-fatal overdose. This provision is developing across Scotland, and this work is key to delivering one of the medication-assisted treatment standards, which are being driven forward by the Drug Deaths Task Force, Scottish Government and others, including SDF. Indeed, SDF are planning to scope existing assertive outreach provision in Scotland and develop guidelines on delivery models. We have three speakers today from across Scotland: Claire Johnson from Hillcrest Futures, Dundee; Jackie Rowland, NHS Greater Glasgow and Clyde's City Centre Outreach Team; and Fiona Nichol, NHS Borders Addiction Service. We'll hear from each of the speakers in turn, and then we'll have a question and answer session at the end. Attendees can submit questions throughout the webinar, and the questions tab appears on the control panel, which should be on the right side of your screen. My colleague Kirsten Horsburgh will join us for the discussion session at the end of the presentations, where she will summarise the questions being asked by the webinar attendees. So, if I can begin by introducing Claire as our first speaker. Over to you, Claire.
Hi, thanks, Dave. I'm one of the specialist harm reduction workers for Hillcrest Futures at the Cairn Centre in Dundee. As most people will be aware, Dundee is branded drugs death capital of Europe, and the spotlight is really on Dundee services to make radical changes in response to this. So for the purpose of today, I'm going to give a brief overview of Hillcrest Futures' response to non-fatal overdose in Dundee, but highlighting particularly the assertive outreach model and the data that we've collected for this model during COVID-19. Hillcrest Futures has employed the first specific non-fatal overdose worker, and this role was part of a test to change. The non-fatal overdose worker will take the lead on the daily non-fatal overdose call and on the assertive outreach model. For those of you that aren't aware what the non-fatal overdose call is, again, this is a first. It's one of Dundee's strategies in tackling drug-related death. This was originally an emergency response to non-fatal overdose, but this looks to be the norm going forward. The call permits information sharing between essential partners, and it is a multi-agency approach. The call takes place every day at 10 o'clock. As we know, having previous non-fatal overdose increases the likelihood of having a drug-related fatality. The call is informed by the Scottish Ambulance Service, who will detail anyone who's had a non-fatal overdose in Dundee in the 24 hours leading up to the call. If this is on a Monday, it can be up to 72 hours. The chair of the call gives details of each incident, and the most appropriate service takes ownership of the person who's had the non-fatal overdose, with every effort being done to see the person within 24 hours. As I said, if the call takes place on a Monday, it can be up to 72 hours. As I said, it's the non-fatal overdose worker who takes the lead on the assertive outreach model and is joined on the call and on the outreach by an NHS Tayside harm reduction speciality nurse. The partnership between ourselves and the NHS Tayside in response to non-fatal overdose has been fantastic, and we've recorded data for 12 weeks during COVID between the 28th of April and the 21st of July. This data highlights the impressive outcomes from the assertive outreach model. Our assertive outreach model consists of one non-fatal overdose worker, one NHS Tayside nurse, and during COVID, we've utilised unused community transport and a community centre worker who would have otherwise been on furlough. It takes place 1 to 4, Monday to Friday, and we visit anyone relevant to our service from the call. During our visit, I'm the Hillcrest Futures member of staff and NHS Tayside. The person receiving the visit will be offered naloxone. They can be supported onto OST, which we know is a protective factor for non-fatal overdose. Harm reduction advice will be given, bloodborne virus testing, wound care. We'll also address the person's welfare, and they'll be offered support with housing, food and benefits, or at least signposted onto the relevant service. I'd like to show you some of the data which we've collected, and I'm sure you'll agree this is a benchmark for assertive outreach and non-fatal overdose response in Dundee. Could we have the first slide, please, Andy? So from this slide, we can see that we've made 290 visits, but over 134 individuals. The reason there's more visits than individuals is because we've visited some people more than once. As I said, that's between the 28th of April and the 21st of July. It's only a 12-week period. So seeing that number of people has been tremendous. Could I have the next slide, please, Andy? So at Hillcrest Futures, we do believe that everyone is high risk, but from the evidence base and the research done, we know that males over the age of 35 are the highest risk group. And we can see that we've been able to target this population through outreach, with 46.3% of individuals that we're seeing are in that males over 35-year-old category. We'll also know that recent prison liberation is a massive risk for non-fatal overdose, and through this assertive outreach, and 9% of all of the 134 people were actually recent prison liberations. So again, we've been able to target this population. In addition to this, Hillcrest Futures have been able to secure funding to give packs to prisoners that are leaving, that where they can phone up for support. They can be issued with a mobile phone if they don't have one, so they can receive the support that they need. Could I have the next slide, please, Andy? So whilst on this assertive outreach, this is sort of detailing the interventions that have been given. So one of the big things we know is getting naloxone out there, and we'll have our non-fatal our OD Not Me campaign. But in the 8-week period between 28th of April and the 30th of June, 75 naloxones were distributed from the assertive outreach. That was 38.1% of the total number of naloxone kits were given out in Dundee were actually given out through this assertive outreach model. Also, 52 deliveries of injecting equipment were given, and 72 people were either referred into a programme for support with welfare, or we were actually directly offering support with that. Could I move on to the next slide, please, Andy? So this is nurse-led care. So out of all the people we've seen, 10 people were given wound care, and 26% of all those seen were offered support onto OST. As I stated before, we know that OST is a protective factor for non-fatal overdose, and this is a brilliant result. As maybe some of you are aware, this week on Tuesday was actually World Hepatitis Day, and you may have heard or read that Tayside is the first area in the whole of the world to be able to say that they've effectively eliminated Hep C, and it's an absolute pleasure for myself to be actually part of a team that's been involved in this. The bloodborne virus team are based within the Cairn Centre in Dundee, and that link that we have with them on the assertive outreach and through assisting the eradication of Hep C has been brilliant. At the start of assertive outreach, there was 49 positive infections known that were lost to follow-up in Dundee, and on the 1st of June, we started doing blood tests through the assertive outreach. Out of the 23 bloods that were taken from the 1st of June up until the 21st of July, 12 of those were part of the 23 that were lost to follow-up. So this is showing that the population that were chaotic and having non-fatal overdose are the same population that are being targeted for, that are needing to be targeted for bloodborne virus. So 24.5% of all of those from lost to follow-up were actually seen through the outreach model. Again, this is another great example of the work being done through outreach. In summary, I would just like to say that between the for Hillcrest Futures, between their non-fatal overdose worker, their input on the non-fatal overdose call, and through our practice and assertive outreach, we've met all of the good practice indicators as recommended in the government endorsed Staying Alive report from yourself at SDF. And the figures, bear in mind, are based on one non-fatal overdose worker and one NHS Tayside harm reduction nurse over just 15 hours. So I really do believe that this should be the benchmark for assertive outreach in Dundee going forward, and for this response to non-fatal overdose in Dundee. And I would like to put it back to you, please, Dave.
That's great. That's terrific, Claire. Thanks very much for that. And I'm sure that will generate lots of questions in the question and answer session. Can I move to our next speaker now, Jackie? Over to you, Jackie. Thanks.
Hi there, I'm Jackie Rowlands. I'm a nurse with the City Centre Outreach team in Glasgow. Just to give everyone an idea of what we do, we are a harm reduction service. We operate Monday to Friday in the City Centre of Glasgow. We have a satellite clinic that operates from Abbey Chemist in Trongate. That's Monday to Friday, 9 to 5. Within the clinic, we provide IEP. We also provide wound care. We do training for naloxone and provision of kits. We do dry blood spot testing, and we've also just introduced point of care testing for HIV with immediate results given to patients. We also deal with patients being referred on to other services for ORT, for opiate replacement therapy. Another branch of what we do is we have an outreach team who go into the city centre on foot with backpacks, providing kind of the same service. Obviously, we're not allowed to do dry blood spot testing or point of care in the street in Glasgow, but we've recently had the provision of a van that we're able to use with outreach as well. So we're quite fortunate in that we've got a fixed satellite clinic, we've got an ambulatory service, and we've also got the van, which gives us a bit more privacy. Still able to do IEP provision, testing, and wound care, etc. for that. So we consist of a team of 2 nurses, 2 senior nurses, and a band 3 healthcare support worker. So we're able to kind of, with the dynamic that we've got, we're able to always have someone covering the clinic and people doing outreach in one form or another. So as I say, Monday to Friday, unfortunately, we don't have any kind of weekend cover for that. But at the moment, what we've found is that during the outbreak for COVID, we've noticed that in Glasgow, particularly with IEP provision, there have been less transactions, but there have been more needles given out. And I think that's largely because we were encouraging folk to take more needles at each transaction. And it was also largely due to the fact that Abbey Chemist remained open throughout for dispensing of ORT. So people always had Abbey Chemist to go to for their IEP, and Abbey Chemist happens to be one of the busiest providers of IEP in Glasgow and Scotland, I believe. So that was always a point of call for people to come, to get their wounds fixed and stuff. Now, initially, through COVID, due to like service interruptions and stuff like that, we did see a bit of a dip in interaction for things like wounds and dry blood spot testing. But what we've noticed is a sharp rise as well. Just within the last month, we've noticed a sharp rise in wound intervention. For example, in May, we did 70 odd wound interventions. That's injection injuries. So it's a lot of time, 90% of what we're seeing are venous leg ulcers as a result of vascular disease. Seeing quite a few abscesses, things like that. So we did see a big jump. We did see a big spike as well in naloxone provision. We provided at least 200 naloxone. That was in April. And we kind of attributed that largely due to the fact that the homeless population within Glasgow and the city centre has been swelled by the fact that a few of the city centre hotels have been utilised as accommodation for people who are homeless. So we've seen the population swell to possibly about 500. So that's kind of keeping things a bit more consistent after the initial lockdown where we saw a bit of a dip. And that was due to kind of organisational stuff as well. So we are seeing that there has been an increase in that. And in terms of non-fatal overdoses, there has been an increase in non-fatal overdoses, and us directly dealing with that inside the pharmacy and just in the locale, that kind of city centre area. Oh yeah, we work closely with the Sandyford nurses and the HIV nurses who also have outreach teams in Glasgow. So we link in with them, which means that we're able to kind of refer folk back into all the other services as well. And as for us doing outreach in Glasgow, we're still providing IEP, needle exchange on the street. We are able to enter the hotels. So the hotels where the homeless accommodation population are being put in Glasgow, we're able to use that as well as a kind of base for seeing patients, which has been really helpful because most of our chaotic patients are based in it's 4 hotels in the city centre. So that's been quite helpful for us as well in terms of linking in with patients. Sorry, I've lost my notes here, I'm getting nervous. What we also do as well is we record on different systems. So we've got 3 different systems that we record on so that our information can be shared with other services as well. So we can access Clinical Portal, we access the NEO system as well, which allows us to record for all the different services, which hopefully means that people are able to communicate with each other in terms of interventions. So yeah, that's me finished. Thanks.
That's great. Thanks, Jackie. We'll come back to you, I'm sure, with lots of questions around that. That's really helpful. If we can move to our third speaker, Fiona, who's speaking to us from Galashiels. Fiona.
All right. Hi, I'm Fiona. I'm the manager of the Borders Addiction Service. What I was going to do first was just put a little bit of context about our service, because it's probably quite different than some of the cities. The Borders have a population of 115,000, and compare that to Glasgow City. And Dave, you might have to fact check this, because I just did it on Google, but Glasgow has over 101.5 million. Area kilometres squared, though Glasgow is about 175, where the Borders is over 4,700. So we're quite a small population, but cover a really massive area. And for instance, we're based in Gala. If we needed to go and see someone in Eyemouth, that's an 85-mile round trip. So that's quite a lot of challenges for us there. The team were kind of 20 whole-time equivalents, and we've got 6 NMPs, which is excellent. And the staff we're a mixture of admin, support workers, nurses, psychiatrists, psychologists, GP specialists, pharmacists. So we're quite a small, robust little team. So I was going to talk a little bit about our engagement support service, which is called S-Team, and a little bit about how it was running before lockdown. So with the new monies in 2019, ourselves, We Are With You, which was formerly Adaction, and the ADP met, and we decided what we really needed in regards to the drug-related deaths, etc., was some kind of assertive team. Now, we called it an engagement support team, but they are very assertive and can be very reactionary and stuff like that. The people we decided to target were people in service that were just not attending appointments, who in the past possibly would have been discharged, people that were dropping off their prescriptions and the key worker weren't easily able to contact them, people who weren't in service, they're kind of hard to reach, that felt that there was barriers that they couldn't get into service, and also the non-fatal overdose people, particularly ones who weren't in treatment. We still struggle to try and get that information with the non-fatal overdoses, which is a kind of different story, but it's hopefully going to be improving, and certainly A&E recently have informed us of a couple, which is great. So around about the same time as we were doing the assertive team, we also had a look at the way that we delivered the service. And I think similar to many other services, we had about a 40% DNA rate. So what it always kind of surprised me that a lot of our people don't go to their GPs, yet we'd sit in healthcare centres waiting for them to come to us, and then surprised when they didn't. So we kind of looked at that and kind of thought, what were we going to do? And what we decided we wanted to do was try and offer people something that they would actually want to come to rather than need to come to. So we set up the kind of holistic drop-ins, and we had 3, one in Eyemouth, one in Hawick, and one in Galashiels. And Esteem were very much involved in setting up the one in Gala, certainly. And what we did, we offered kind of hot drinks, food, IEP, naloxone, BBV testing. We could have offered sanitary protection. We had a clothes horse line thing for people to take clothes. We could offer food parcels. And we'd also do kind of pop-up events, and that could be anything from, we had sexual health come, we had a kind of dental hygiene, but we also did things like we had acupuncture, and we'd had haircuts just before Christmas, and a kind of music session and stuff like that. And we also would offer same-day prescribing if it was safe to do so. So this was it was really taken off, and it was such an exciting time for us before lockdown, obviously. And the other thing that we could do is Esteem, where they would be identifying people that weren't engaging in treatment, that were maybe using the injecting services, etc. They would actually go to their houses, engage with them, and pick them up and bring them to the drop-ins and support them in the drop-ins. And then again, you know, they could get the same day prescribing, and I think we were really fortuitous that at lockdown, we kind of mopped up quite a lot of people that had been on the peripheries of the service that we were hard to get in. So that's how things were. The other things that our Esteem were doing and still do is similar to the other services. We could provide phones for people, offer bus passes. They would see people either in their home, in cafes, wherever people wanted to be seen. They'd give them lifts if required. We offered IEP, naloxone, bloodborne BBV testing. We've also just done our first Hep C treatment in the community, and though Esteem weren't involved in that one, it'll be something that we probably will use again, and that was people that are not going to the Borders General Hospital for their treatment, but identified as Hep C positive. So that's another quite exciting thing that we're doing. Another initiative through Esteem, though it was one of our nurses, Debbie, that sorted it out, is we started a football team for some guys. A couple of women turned up as well, and it was just a bit of a kickabout, but at the end there was a really kind of positive, peer supportive type element to it, with a lot of the people kind of talking about what was working well and what wasn't, and very supportive of each other. Hopefully we might be able to get that up and running soon. What else? Oh, I was going to do the non-fatal overdoses, though we do struggle to get that information, but it has come through recently, and it's just to kind of to show you what happened. Is on the Monday we heard through the BGH that someone had a non-fatal overdose. We passed on to Esteem. They'd contacted them. They arranged to see them in their house on, I think it was like the Wednesday or Thursday or something like that, and we got them on treatment and onto buprenorphine on a kind of therapeutic dose, and that was all within a week's period. And this was a guy that we knew of but wasn't in service, so that was really good, and obviously we want to continue doing that. I think the other thing that Esteem are really good at, a lot of our guys in the Borders, everyone kind of knows everyone and all that kind of stuff, and part of it is kind of dismissing some of the myths that people hold, that, you know, the kind of old way that we work that could be a bit punitive, that it was discharging if people weren't attending, or they kind of have this belief that if they ask for IEP that there's going to be some kind of punishment for it or whatever. So it's dismissing all those myths as well, and kind of getting people through the door. With Esteem, they run with about 25 people on their books, and we deliberately kind of protect them for not getting too busy so they can be reactive. And as a manager, I find it brilliant that if we're concerned about someone, I literally can just say, can you go and see these people? And they'll go off and do what they need to do and offer what they need to offer. I think, as I was saying, DNA rates were at 40%, and in this last year, they've been reduced by half to only 20%. Same day prescribing we're continuing to do, and we have, over the period of April to June, which is kind of COVID times, 40% of people were prescribed on same day prescribing, and if you add it all up for over a week, there was 65% that were from being seen into treatment coming through the doors. Our drug-related deaths, though it's not completely confirmed, they have been slightly lower for 2019. But our numbers are low, and we have to keep that in mind. And also there's the long-term kind of trend that, you know, we'll have to see if this continues to see if we're actually making a difference. So that's kind of me. I suppose future developments, one thing we're working on is that Esteem we're in touch with Edinburgh prisons, and Esteem are potentially going to look at visiting people prior to release, so going into the prisons and seeing them and kind of engaging with them, so hopefully the transition of coming out of prison would be smoother. And there's a kind of peer naloxone thing that we're going to put in place, hopefully. And that's me.
That's great. Thanks for all that, Fiona. A lot of information to take in. Can I have all of the speakers back on screen now, and also my colleague Kirsten Horsburgh, and we'll go into the question and answer session. I'm just checking. We've still got Claire. You're still with us?
Yeah, I'm here.
That's good. And we've lost Fiona for the minute. Do you want to come back on screen?
I'm back
Fiona?
on.
Oh, good. Thanks. Okay, Kirsten, do you want to kick off with the first question?
Yes, we've got lots of questions, so I'm glad we've got plenty of time to get through them all. The first one's a pretty straightforward one, and I know a couple of people made reference to it, but just to confirm how the projects are funded.
Okay, can I ask Claire first to answer that one?
The Hillcrest Futures, we're working in partnership with the NHS, so NHS Tayside our input into this. We also get funding from ADP for certain things. I'm not sure on where else we get funding from, but we do have other pockets of funds.
And is that all funded long term, or is any of that short term funded?
No, for the assertive outreach, unfortunately, as COVID's coming to an end, we won't. Not COVID's coming to an end. People are returning to work. We only have transport for our bus up until the end of this week. But I know that Danny, the Hillcrest Futures manager, and Ingrid Haney, the area manager, are looking at other places that can get money from. Also, Brian Stevens from the NHS is working on that with his colleagues to see if we can secure some funding and a bus for taking things forward.
Okay, thanks very much, Claire. Jackie?
We're funded completely by NHS Greater Glasgow.
Yeah. Okay, and Fiona, is that the same for you?
It's the 2019 Scottish Government's funding for 3 years, but hopefully will go on for longer.
Okay, and that's specifically for the Esteem team?
Yep.
Yep, okay, that's great. Thanks for that. Kirsten?
Thanks. So there was reference made to most, if not all, of the services being a Monday to Friday service, and some questions around, are you seeing increased numbers in near fatal overdoses at the weekends, and is there any plan to have weekend provision of these types of services in your areas?
Jackie, do you want to take that first?
Yeah, we don't have any plans at this juncture to move forward with any kind of weekend cover. There are the other services in Glasgow that do operate after the 9 to 5 hours and operate at weekends. So we've got Simon Community Outreach, got lots of different outreach teams, although they don't have a clinical component. They are able to offer IEP, and they're able to provide naloxone and deal with any kind of overdoses. So they're largely kind of like homeless services. But yeah, there are services out with a Monday to Friday in Glasgow that can deal with some stuff.
Okay, Fiona?
Well, as I was saying, we struggle to kind of get the information really about non-fatal overdoses, so I don't have that information to hand whether there's more at the weekend or not. And certainly at this stage, we're not looking at working weekends or anything like that.
And Claire?
Hi Dave, yeah, at the beginning of lockdown for April, May and June, we seen a spike of numbers in non-fatal overdose coming through on a Monday morning on the call following a weekend. And some of those instances it was recent prison liberations that had been released on a Friday, and we do know that there's a link there between prisoners being released and not having that support over the weekend. So we've tried putting things in place and making links with the prison to try and stop this from happening. Us as a centre, we're actually open on a Sunday afternoon, so we can provide harm reduction advice, naloxone, etc. on a Sunday. There's no plan in place just now to have any kind of outreach over the weekend.
Okay, thanks. And just maybe picking up on that point about getting information about near fatal overdoses, Fiona, what are the issues for you locally in terms of struggling to get that information?
We're not getting, there's a protocol in place where the ambulance service are meant to contact us, and it's just not happening. But we're going through another line now, and I think they're just looking at kind of data protection stuff, so we can just get the information directed straight to us, and the Scottish Ambulance don't have to. And A&E, we've got more of a presence there now, and certainly that has picked up, and that's been great that they've been able to tell us when someone's come in. But hopefully, fingers crossed, we'll be able to get the data through the ambulance service in the near future.
Thanks. And Jackie, do you get any information in that regard?
Well, Jo McManus in Glasgow is Health Improvement. She's actually looking to collect that information. So she's been liaising with Scottish Ambulance Service, A&E departments and stuff, and she's actually started up engaging with all the different services that do outreach in Glasgow, so that everybody can collate that information. So Jo McManus is dealing with that just now.
Yeah, but that's information, Jackie. What about following up on near fatal overdoses? Is that in place in Glasgow?
Not for our service, no. And I think that's why Jo McManus is trying to get a point where everyone can actually gather that information to then act on it in a more constructive way.
Okay, no, that's great, thanks. Kirsten.
So there was some discussion about people being supported onto OST from some of the projects, but are all of the projects able and capable of delivering same-day OST?
I think you've answered that already, Fiona, but do you want to add to that first?
Yeah, we try and use the low threshold kind of guidance in prescribing, and where we can, when safe enough, we absolutely do same day prescribing, and that's continued throughout COVID.
Claire, do you want to come in there?
Yeah, as I said, we do support people on OST through the assertive outreach model, and it has been working really quickly. Because of lockdown and not being able to see people face to face, we go out on the bus and we arrange the appointment over the phone with the person who is going on to the OST. A lot of people that we're dealing with also don't have any phone, so they can't have the telephone support. So where possible, we'll have provided phones, but also we will liaise with integrated substance misuse services and arrange an appointment for the person. We'll then go back to the person and let them know what time their appointment is. And then we have a taxi fund that we managed to get a fund through gift aid of £1,000 that we're able to use to transport people in a taxi to and from their ISMS appointment to make sure that they actually get there and back. And this during coronavirus has happened within probably at the most 2 or 3 days, and the delay and even waiting the 2 or 3 days has only been because us trying to liaise between integrated substance misuse services and the client at their home and back and forward on the bus, but it's been very fast and really effective.
So yeah, I think you mentioned in your slides, Claire, was it 26 people that had gone on to OST?
Yeah, 26 people out of the 134 people that went to see.
Yeah. And how many of those would be same day starts? Did you have that information or?
Not for the same day, but every single person that was seen was definitely started within the week.
Yeah. Okay, that's great, thanks. Jackie, do you want to add to that?
Yeah, we've got quite established links, quite strong links with the homeless addiction team and the ADRS services in Glasgow. So whether it's about re-establishing someone who's disengaged on their ORT or getting new patients started, prescribers are really quite keen in Glasgow to get people their prescriptions that day. And we're quite active in kind of engaging folk, making sure they get to the services to pick up prescriptions or get their assessments done. Or indeed arranging for the prescriptions to be dropped off to pharmacies, particularly with the COVID kind of restrictions at the moment. So we've been quite successful at that. The majority of folk, I don't have figures to be exact, but they're getting started on the same day with the prescribers in Glasgow.
Okay, thanks, Jackie. Kirsten.
So Jackie mentioned in particular about an increase in wound care over the COVID period, and just maybe a discussion about any reasons why you think that might have been.
Yeah, absolutely. We are attributing that largely to the fact that the city centre hotels in Glasgow have been used by Glasgow City Council to accommodate a large section of the homeless population and rough sleepers in Glasgow. And because our Abbey Chemist, which is where our clinic is based, is such a central location, we think that that's why we're seeing an influx of people coming in with injecting injuries. Some of them, as I say, are quite advanced chronic venous leg ulcers. That's the majority, about 90% of what we're dealing with. For example, in June, we saw 78. We did 78 wound interventions, whereas prior to the outbreak, we were seeing like maybe 20 a month, which is a big leap. And as I say, I think it's because of that. There's been a swell in the kind of population from almost say like 200 injectors in the city centre up to 500 because of the hotels accommodating a lot more homeless folk in Glasgow.
So you think it's more about the increase in the population than the change in behaviours?
Yeah, I would have to say so. Yeah.
Okay, thanks. Fiona, have you observed that yourselves?
No, not really. I'm not aware of an increase, and certainly if we were kind of delivering medications to people's houses and with the steam and everything, we would always offer IEP and harm reduction information and all that kind of stuff. And I'm not aware that there's been an increase. And usually if there is via the BGH, they do let us know that there's something happening or whatever. So I don't think so anyway.
Okay, Claire?
Our building's been shut, so there's nobody been coming in for wound care. But as I'd mentioned in the presentation, out of the 134 people we've seen through outreach, 10 of those were given wound care, and that was just through opportunistically, whilst visiting the person, they've addressed the fact that they have a wound that they want looked at, and we've managed to look at it at the time.
Okay, that's great. Thanks for that, everyone. Kirsten?
In terms of assertive outreach, which people are more challenging, would you say, to reach? So thinking about maybe people who are using cocaine or benzos, or people who are experiencing mental health problems.
Okay, Fiona, do you want to go first on that one?
Oh gosh, that's a tricky one. Thanks for letting me go first with that one, David. I don't know. I suppose you have to take them all on individual presentation. I don't think we are seeing one's a lot more difficult than the other. We tend to be seeing more of people that are using opiates, to be honest, rather than using a lot of like cocaine or whatever, and with the view to kind of getting people in and onto treatment. In some ways, mental health, possibly not, because it means they can be seen, or they were being seen at their home, and certainly we do kind of doorstop visits, and we're still open for people to come and see us here and things. So I think it's probably just an individual case-by-case basis, the different complexities that people bring.
So you're not seeing, say, for example, people are using more benzodiazepines that are, are maybe more. I think
in the borders they've been using them regardless of COVID. One thing we have is the domestic abuse seems to have gone up. And there's a lot of very vulnerable women out there that we've been really quite concerned about and had to get kind of adult protection involved in things. And that has been noticeable. Yeah.
So just I suppose to add to that question, you don't prioritise any particular individuals because they're all vulnerable in a sense.
Absolutely, and we're lucky enough that we don't have a waiting list, particularly when we had the drop-ins and stuff like that. And also the assertive team, because we keep numbers low and they kind of pass on to key workers and things like that, that they can pretty much, if you said, can you see this person today, they're pretty much able to do that.
Okay, thanks. Claire?
Hi, every person that we go out to see would probably be classed as hard to reach because they're all from disadvantaged communities, and most of them have quite chaotic lifestyles. But I would say because the assertive outreach model is visiting people's homes, a lot of it sometimes will the people that would visit homes and they're less likely to be in are people who are out begging on the streets for their money to further drugs. But obviously during COVID, this wasn't something that was meant to be happening. So we actually, on our assertive outreach bus, we would go and visit places that we know that people would be begging, to try and find people that we would potentially be looking for on the back of the non-fatal overdose call. we would also leave letters through people's doors and ask them to then contact us back. But probably our biggest difficulty through this coronavirus time and the hardest to reach people would be people that wouldn't be in their property through to begging or going out doing other things.
And you mentioned, Claire, in your presentation, the over 35s and the under 35s. Would you see any distinction between different age groups?
Because of the over 35-year-old males being disproportionate and having a large proportion of those that made up, we did see, we didn't actually, I wouldn't say there was any less likelihood of seeing them than anyone younger than 35.
But what about in terms of drug use?
In terms of drug use, I would definitely say the over 35 and over 35 male population has its illicit benzene. Illicit benzene is a massive problem, in particular.
Okay, thanks, Claire. Jackie.
I think I would have to agree with Fiona that you take each case on its own merit, but in Glasgow we're finding that the majority of folk that we engage with, because we are very specific to the city centre, and we're engaging most of the people who inject drugs, who are begging, who are homeless, who are rough sleeping, so there is a really high tariff component to it. But in Glasgow we see huge amounts of illicit benzodiazepine, etazzolam use. Cocaine is a huge issue, and I think that also ties in with the amount of really quite complex wounds that we're seeing, injection injuries and stuff like that. And with the illicit benzodiazepine use, I think that's possibly also evidenced by the fact that, and this is anecdotal from our own team, that the last 3 overdoses that we responded to personally with naloxone, it took 3 naloxone kits to actually stabilise the person. So it's clear that there's not a massive amount of opiate and kind of involved with that particular overdose. So yeah, we still see opiate use in Glasgow, but cocaine really is a big issue for us. And we found out recently as well that people are saying that they're able to now buy, it used to be traditionally folk would buy £20 bits of cocaine, now they're saying that you get it in £10 and £5. So I don't know if that's maybe like another response to COVID and possibly supply issues. Again, this is anecdotal, these are discussions that we've had with patients who are attending clinics.
So do you think the increase in benzo use is linked to heroin purity?
I'm not too sure. There is also, you know, a kind of school of thought that possibly it's about alcohol pricing as well, that people who traditionally may have consumed alcohol, which is now more expensive. There's a lot of different theories surrounding that, but that's another one that I think sounds quite reasonable. But I wouldn't like to make any kind of definite statements surrounding that, but Glasgow's always had its issues with benzodiazepines, always.
Sure. Mm-hmm. Yeah, that's true. Okay, Kirsten.
Thank you. So we've still got quite a few questions, but just to remind people, you are still free to put some more in if you have any come to mind. So just on the, Jackie mentioned there about naloxone, so I'll just go to this question now. Have you noticed that there has been more demand for naloxone? Because obviously in the past, you know, it's been quite a push from services to get naloxone out, but have you noticed a shift that people have actually been asking for naloxone? And I'm just going to lump it in with another question as well. Do any of the projects involve peer workers?
Okay, Jackie, that looks like that's coming to you first.
Yeah, we've definitely seen a big increase in naloxone, because traditionally for us, when we're doing IEP provision, folk want to get in, get their stuff and get out, so they're not really open to a lot of discussion or persuasion, so it's been very difficult. You kind of find yourself almost like a double glazing salesperson trying to get folk to take naloxone from you. But we found that folk were actually more amenable to it during that period, and for example, we gave out 180 kits of naloxone in April, which is quite a significant amount for us to have done. As I say, Abbey Chemists was still operating normal business hours, so we were still getting quite a big footfall for IEP, but certainly naloxone provision has gone up. People are far more open to taking kits, whereas where they weren't before. I can't really think of a reason for that, but they were just delighted with that uptake, and it seems to kind of, we're still getting a wee bit of success, not quite spiked like that, but we're still getting a bit more success with the naloxone provision.
And the peer supply, Jackie?
Peer supply, yeah. We work with, one of our staff has got lived experience, and also we work in partnership with one of the peer support guys. I've forgotten his name, Jim Thompson. He's the peer worker who. Yeah, Jim Thompson. He's the peer worker who does the provision in Glasgow for naloxone. So yeah, got good links with him.
That's good. He's got a name check anyway. That's good. Claire.
Yeah, hi. Just to reiterate what Jackie was saying, for some reason, just recently, people are more amenable to taking naloxone. It's not been such a push. We do offer every person that has came to the door naloxone, and every single person that we go to visit on outreach, we offer them 2 naloxone kits. But
Wow.
where previously there's maybe been a bit of resistance, people are more amenable to it. Just even an example of how we gave naloxone kit to someone that we visited on outreach, and then 2 days later that same person used the naloxone kit we gave them on outreach to save someone else. So that was a great thing that happened through giving out naloxone kit. And as far as peer support goes, Hillcrest Futures do actually employ, I think, about up to 5 people that are working as peer support workers with lived experience. Either voluntarily or work sessionally with us, and they are great at actually offering people naloxone as well.
Okay, great. Fiona?
Yeah, and my evidence is because we've had to keep on reordering more naloxone, and at one point I can remember we've got a kind of box where we keep it all, and someone's saying have we got any, and I was saying yeah, there's loads in the box, and it was all gone. So I think it's definitely been taken up. About the peer naloxone, Kirsten, you're maybe easier to answer that, because in the Borders we're maybe going to be kind of piloting a peer naloxone initiative. I don't know when, but it's something that's kind of in the background that we're going to be looking at.
Thanks. Yeah, I don't know to add to that, Kirsten, but we haven't got any money for that yet. But I think that we're working on it.
Watch the space.
Kirsten?
So it's been discussed in a lot of the presentations, but maybe just to, a couple of pointers on this. What would you say has had the biggest impact on your work through this COVID period? What's the biggest impact that COVID's had on affecting the work that you're doing?
Claire, do you want to take that first?
Well, I could probably start with a positive. During COVID, we obviously had the opportunity to utilise community transport that wasn't otherwise being used, and a community centre worker who would have normally been working in the community centre. So it allowed us to trial this new assertive outreach model, and it's worked so well. We can't really see any way back from that. So I know, like I said in my presentation, every effort's been made by NHS Tayside and from Hillcrest Futures to try and make sure that we can continue it going forward, because the COVID has allowed us to try things that we wouldn't have tried otherwise, and the results for it have been amazing.
Okay, thanks, Fiona.
Yeah, definitely the kind of downside has been our kind of holistic CAFE type drop-ins that they went before even lockdown happened, actually, because we were just like, we can't continue. It was all just getting too big and too scary. And that's such a shame, because we've done a kind of satisfaction survey, and the people going there really took ownership of it and really liked it. And it was a really exciting time for us. And we were looking at expanding that, and we've got more money through the Challenge Fund to kind of expand it further and things like that. So that going was a definite negative point. I think a plus side is that in the past, before the drop-ins and stuff like that, we were just very clinic based, and people were just seeing them one after the other, back to back. And actually now going out to people's houses and seeing people maybe not in their house but in their garden or whatever, that's it's been a really positive experience, and kind of getting a bit more of a view of how people are living rather than just seeing them in a clinic. And that's something I definitely, when we can do home visits and things like that without all the PPE, that's something I'm definitely wanting to keep up. and it's the people that don't attend as well, but we're probably seeing them as much, if not more, than when we used to just sit in clinics and wait for them not to come.
Just to add to that, Fiona, what about the moves away from daily supervised dispensing? What are your thoughts on that going forward?
Well, pros and cons again. It was terrifying, I think, to begin with, to take everyone off supervised, and we did have a couple of drug-related deaths with other people's bottles of methadones found there, and that was just really heartbreaking, to be honest. So we did get people. We went out actively kind of testing people, and if we had to put them back on to daily supervised, we did. But other ones that are doing well, then we're happy to let that go as it is just now. You know, so that's a positive. For some people, they're doing much better than we maybe anticipated.
So you've not any thoughts on the proportion that would, say remain on or go back to daily supervised dispensing?
I not off the top of my head. And
no,
it's
good. Sorry, that's not a fair question. Yes. Yeah. No, I mean, I think it's it's interesting because I think the last week's webinar, it was one of the speakers was suggesting it should be 10%. But of course, anyway, I think that will come out obviously over time, and it's not really fair to judge that at the moment when we're still in a degree of lockdown. Jackie, do you want to pick up on? So you're muted there.
Yeah, sorry. The biggest impact on our work.
Yeah.
I would say, as I mentioned earlier, the fact that the population was kind of swelled by the hotels in the city centre accommodating far more homeless folk. Because we've never actually changed the service in terms of people are still able to access our clinic at Abbey, where we're still doing outreach. So we weren't really interrupted by what we were doing because we're kind of like doing that outreach anyway in our clinic, but because we had full PPE, we were still doing wins and stuff like that as well. So I'd say the biggest impact in our work was the swelled population of homeless folk due to the hotels. And the fact that also patients weren't able to access the homeless addiction team for GP services, etc. So you did see more folk in terms of that. We were lucky because we were able to access the community pharmacy team who would prescribe folk with antibiotics and stuff. So we were still able to get folk treatment and interventions, even though they couldn't get to the GP. But we were seeing more of them because of that.
Okay, thanks for that. Sorry, we're getting a bit of background noise. I don't know whether someone can mute themselves, maybe.
Yeah, shut up.
that's the better way to do it. Okay. Yeah. Well, we'll invite him on the webinar, I think, shall we, to see what he's got to say. Okay, Kirsten, I think we've still got a few minutes left. So, you got any more questions?
Yep, I do. There was some questions on the near fatal overdose information that's garnered from the ambulance service and whether you need to have consent from the person prior to contacting them.
Okay, Claire, that's for you first.
No, you don't need consent before contacting them. We just received the report from the Scottish Ambulance Service in the morning, which details the incident, and then we, because it's a response to protection of the person, which would be a protection of a vulnerable adult as well. So, and to be honest with you, every single person that we did manage to trace at their home was delighted that we'd came out to see them. And the response was kind of all the same. Oh, I can't believe someone's bothered. I can't believe someone's actually cared to come. It's been a great response.
Okay, thanks. And Fiona, I know you've had some issues locally with that. Do you want to add to that?
No, we don't ask for permission. If we do get the information, we will kind of give them a ring or even chap their door or whatever we need to do.
Okay, Jackie?
It's not a situation that we've ever had to deal with, to be perfectly honest with you.
Yeah. No, that's fine. Okay, Kirsten?
I'll chuck two in together to try and get them in. So in developing your service, did you model it on any existing services? And are any of the projects that are doing assertive outreach actually doing any sort of discarded injecting equipment collection, needle collection?
Okay, who wants to go first? Jackie?
Yeah, we pretty much are working on a model of an outreach team that existed in Glasgow between 2014 and It was funded up until 2017. I was part of that team, and that was made up of social care staff, and it worked on the same kind of basis, doing outreach to the city centre in a very clear area, the square mile, providing IEP, wound care, naloxone and dry blood spot testing. So we were kind of based on that, and that was quite a successful model. But in terms of us collecting used injecting equipment, no, we don't do that. If we do map any areas on any level, there is a telephone number that we can call for Glasgow City Council to come and safely remove and clean up the areas. And they wouldn't do that if it's private land. So there can be quite contentious issues as well in Glasgow if it's something that's deemed to be private land. So if it's owned by British Rail, or then Glasgow City Council would refuse to do it, and they would put that responsibility back to the particular company or the private landowner.
So Jackie, were you saying that the service disappeared for a period of time and is now back in place in a similar model to the way it was?
Mm-hmm. Well, basically, it was two different services. There was the outreach team in Glasgow, which operated from 2014 until 2017. That was funded by the ADP. And as I say, that particular model, the funding for that ceased in 2017. So with the city centre outreach team, that is something that we kind of resurrected almost. I wouldn't say we resurrected that exact model, but we looked at a model that worked in Glasgow and kind of, looked at reflecting that to some extent, but with a different skill mix, so with a different kind of set of staff and different qualifications, etc.
That's great, thanks. Claire.
Hi. Our assertive outreach model is an NHS Tayside and Hillcrest Futures joint effort. There was no clear set out in what the model was going to be, and it's adapted continuously since we started doing it. So it was just a non-fatal overdose worker and a harm reduction nurse going out and visiting people on the back of the non-fatal overdose call. But what's came of that is an unexpected outcome of when we're going out and visiting properties, people have approached the bus or the van or workers and asked if they could also receive support. 9 times out of 10, the people asking for support had previously had non-fatal overdose. They would collect naloxone, they would come to the bus and collect injection equipment. So again, at first we didn't even give out injecting equipment from the bus, but as the service has adapted and grown, started improving what we were doing based on the needs of the service. So we kept changing it. So we've been now given injection equipment from the bus, we're given OST, given naloxone. So it's really, really developed from a service that really started out to just go and visit people as an emergency response to non-fatal overdose, and has changed into this massive service where loads of needs of the client are being met, and it feels excellent.
Okay, that's great. Okay, Fiona, you get the last word. I think we're just about to run out of time.
2 minutes to go. Esteem, no, it wasn't based on a model. It was really a kind of trial and error type situation we had, and it's like I was saying, ourselves, and we are with you, and we are with you managers, and myself would kind of meet weekly and just suck it and see a bit, just trial and error, and things worked really well. We'd continue, and some things that we said, no, we can never do that, like just going up to people's doors and chapping them without letting them know we're doing that if we feel it's necessary. So it wasn't a model, and it's growing and developing all the time. We've been up and running for about a year, but it feels quite a good place now.
Okay, that's excellent, and that ties in with what I mentioned at the start, a piece of work that we were looking to do to scope existing models and maybe come up with some good practice guidelines or just describe what's already there. So that's excellent. So sadly, that is the end of the webinar today, but it will be, or it has been recorded and will be published on the SDF YouTube channel as soon as possible. You can also view all 15 of our previous webinars there. We'll be sending out an evaluation, and it would be excellent if you could complete that for us. We are taking a webinar holiday for the next 2 weeks. Certainly our staff need a well-earned rest from these after 16 episodes. So hopefully you won't miss us too much over the next 2 weeks. So our next webinar will be held on the 21st of August at 1 PM, and the focus of this webinar and the one on the 28th of August will be on International Overdose Awareness Day. The webinar on the 4th of September will focus on rural issues. So I'd like to thank all of you for attending, and a special thanks to the SDF staff who've helped deliver our webinars to date, and in particular the behind the scenes technical staff of Andy Coffey and Sophie Milton. And finally, I'd like to thank today's speakers, Claire, Jackie and Fiona, for what has been an extremely informative session. Thanks again, and goodbye. Thanks a lot. Bye now.
Thank you.
Bye.